the title of this topic is taken as antibiotic resistance breaker. So before going into the topic, we'll just have a brief review of what is a urinary tract infection and what are the approaches for dealing with MDR as well as XDR bacteria. So urinary tract infection is an inflammatory response of the urothelium to bacterial invasion. And urinary tract infection is usually associated with the bacteriuria and pyuria. And bacteriuria is the presence of bacteria in the urine, and the usual growth that is described for diagnosing this is about 1 lakh colonies per ml. And pyuria is the presence of white blood cells, and it is indicative of an inflammatory response of the urothelium to bacterial infection. And as you all know, bacteriuria can be symptomatic or it can be asymptomatic. And the magnitude of the problem is quite extensive. So the UTA is estimated to affect about 150 million people each year worldwide, with an annual incidence which is more common in women when compared to men. So these are a few data which are published from the Indian literature. So as you can see, the incidence of UTA in the females is high, especially in the pre-peak reproductive age group. And this incidence of UTA in pregnant women. These are all Indian data which have been published. So epidemiology common in women, and about 50% of the women experience at least one episode of UTA at some point in their lifetime. And recurrent UTA occurs in about 40% of the women. And incidence of the UTA increases markedly in elderly. And bacteriuria is found in about 21% of the women and 12% of men over the 65 years of age. And in pregnancy, this is a real problem. You have to treat these pregnant women, otherwise it can lead to a lot of complications, including ascending infection as well as acute pyelonephritis. And the incidence is much common in patients with the diabetes, and you compare it with patients without diabetes. And instrumentation of the urinary tract often is associated with UTA, especially sometimes it can lead to MDR as well as XDR infections. And if you look at the organisms which cause UTA, E. coli dominates the group, and E. coli is a major culprit in symptomatic and asymptomatic patients, followed by Klebsiella and other gram-negative enterobacter like Citrobacter, Enterococcus faecalis, Proteus. Then rarely you can get Staphylococcus aureus, Streptococcus, and Pseudomonas. So the range of organisms is quite diverse, with E. coli topping the list. And urinary tract infection occur in women who are usually healthy, and it is usually an interaction between bacterial virulence and host defense. And virulence is the ability of the bacteria to adhere to epithelial cells and cause damage. Host defense is the ability of the body to fight infections. And it is an interplay between an increase in the virulence and decrease in the host defense, which ultimately leads to a symptomatic infection. So urinary tract infections can be broadly classified into community-acquired infections. This is one way of grouping urinary tract infections. As you look at any infections in a general in our patients, like when a patient presents with pneumonia, we usually think whether it is a community-acquired pneumonia or a healthcare or a nosocomial associated pneumonia. Similarly, urinary tract infections can be classified into community-acquired infections, and which are usually infections occurred in the community, and nosocomial infections. And these are infections which are occurred in the hospital, usually as a sequence to sequelae to instrumentation. Then again, urinary tract infections can be classified as uncomplicated UTA and complicated UTA. Complicated UTA occurs in a complex host with someone with a metabolic abnormality like diabetes, abnormal urinary tract. When pregnant women, hospitalization is required in many cases. And usually there is an obstruction to urinary flow, congenital anomalies of the kidney, calculi of the kidney and the ureters, benign prostatic hypertrophy, prostate or bladder cancer, and neurogenic bladder. All these are settings in which complicated UTA occur. And in a transplant scenario, it's also a complicated UTA. So again, the organism in uncomplicated cystitis and complicated cystitis, again, it is E. coli which tops the group, which is followed by other organisms like Proteus, Klebsiella, Enterococcus faecalis, Acinetobacter, etc. And if you look at the upper urinary tract infections like pyelonephritis, again, E. coli is a dominant one. Then there could be Pseudomonas, Klebsiella, Enterobacter. All these organisms are there. And if you look at the patients who go into real sepsis, again, it is almost the same spectrum with E. coli topping the group. So it is often found that in patients, if you look at the antibiotic profile of this, the sensitivity profile of these patients, it is found that the antimicrobial resistance rates were higher in patients in UTI without sepsis. And again, you do not require a full-blown sepsis, and still you have got more of an antimicrobial resistance rates. And antimicrobial resistance rates is especially prominent with gram-negative uropathogens. And the crux of the thing is that you have to have an antibiotic surveillance. You need to have a close infection surveillance program. Sort of strains that you're dealing with, the antibiotic spectrum that is that can be used in your patients. So this is quite mandatory. Now, as I already showed in the previous slide, the incidence of antimicrobial resistance is quite high, even in patients who do not have a florid sepsis. So what are the general mechanisms of antibiotic resistance? One is efflux pump. This means that the antibiotic reaches a bacterial cell. However, the bacteria push out the drug by means of efflux pumps. And these efflux pumps actually require zinc and magnesium ions for this proper functioning. This is important. So these efflux pumps are important in kicking out fluoroquinolones, aminoglycosides, tetracyclines, beta-lactam, and macrolides. Then another way of antimicrobial resistance is by blocking the penetration or the entry of the drugs, which include beta-lactams, tetracyclines, fluoroquinolones. This can occur at the outer bacterial membrane layer, or it can also occur at the biofilm layer. And third mechanism is inactivation of enzymes. So this we commonly know like beta-lactamases. So beta-lactamases lyse the beta-lactam ring of the beta-lactam antibiotics and render it ineffective. Then another mechanism, the fourth mechanism, is target modification. Like the bacterial cell acquire plasmids, or they undergo mutations so that the target fraction of the antibiotic is altered. This can happen with the fluoroquinolones, rifampicin, vancomycin, beta-lactams, macrolides, or aminoglycosides. So these are the general mechanisms of antibiotic resistance. So there are various published studies which have demonstrated the antimicrobial surveillance and research networks. So they have found out what the incidence of antimicrobial resistance and the bacterium which is commonly associated with various body fluids. Now, what is an antibiotic resistance breaker? So antibiotic resistance breaker is a drug which, when combined with an old antibiotic, render this old antibiotic quite effective and breaks the inherent resistance to this antibiotic. So these antibiotic resistance breakers are capable of resensitizing the resistant bacteria to antibiotics. So this is a definition of an antibiotic resistance breaker. And how do they achieve it? And one of the classical antibiotic resistance breaker is EDTA, disodium edetate, and it targets multiple resistance mechanism, which I have already shown. So the EDTA helps in binding to zinc ions, thus inhibiting the activity of the beta-lactamases enzymes. It helps in the better penetration of the drugs, increase periplasmic concentration, therefore increases the activity. It causes a degradation of the biofilm. It inhibits the transfer of antibiotic resistance by conjugation. So the antibiotic resistance is achieved by bacteria, and they transfer the genetic information needed for the antibiotic resistance by conjugation. And this mechanism is prevented by this resistance breaker. And it inhibits efflux pumps and causes increased periplasmic concentrations. So one combination that has been tried out as an antibiotic resistance breaker is ceftriaxone sulbactam. So if you look at our most of our clinicians, you might be experiencing the amount of XDR bacteria that you come across in with the patients. And if you combine ceftriaxone sulbactam along with EDTA, it is found that this acts as an antibiotic resistance breaker, and it inhibits and it causes significant synergistic activity with ceftriaxone, sulbactam, and disodium EDTA. So this is marketed by Cipla as Celoris. So this is a molecule. So this is a ceftriaxone molecule or the beta-lactam antibiotic. This is combined with the beta-lactamases, that is sulbactam, and this whole molecule is combined with the disodium EDTA. So this is a ceftriaxone sulbactam EDTA, or commercially available as Celoris, and this is a classical antibiotic resistance breaker. So this is a cartoon which shows how this antibiotic resistance breaker works. So one, as I already told you, is by increasing the membrane porosity. So membrane porosity is actually again dependent upon calcium. So this negatively charged sphingolipids as well as proteins which are found in the outer membrane, for its stabilization, it requires interaction with calcium. So when you use disodium EDTA, it chelates the calcium and it increases the membrane porosity of the drug. Then the other mechanism, it downregulates the efflux pump. The efflux pump requires zinc and magnesium for their action, and EDTA chelates the zinc and magnesium, so the efflux pump is rendered ineffective. Then it prevents the bacterial conjugation, that is a plasmid transfer, and it downregulates the production of MBL, ESBL as well as MBL production by chelating the zinc ions in the MBL in this enzymes. So these are in general, the four mechanisms of action of these antibiotic resistance breakers. So when you compare the penetrance of the drug, the penetrance is quite high. That is, outer membrane penetrance can go up in the ratios of 1.8, 2.2, 6.9, and 2.5 to 2.3 times higher than imipenem, cilastatin, meropenem, colistin, cefeprazone, sulbactam, piperacillin, tazobactam. So penetrance of the drug is actually quite enhanced with the use of EDTA. So these are the periplasmic concentrations which are obtained with the use of Celoris. So you can see that the concentrations are actually, the periplasmic concentration of the antibiotic is actually very high with the use of this EDTA. So this again, Celoris has the least degradation and the maximum stability of ESBL enzymes. Then there are various data which are which again shows the efficacy of this EDTA operation. So the conclusion is that the pharmacokinetic as well as the pharmacodynamic indices of combination therapies are very high, are very suitable, and it is quite effective in countering MDR.
Joe's not audible.
Can you hear now?
Yes, very much. Please continue.
Yeah. So this is just one study which has been published. The major concern with the use of this drug is that there is still there is no big large-scale randomized trials which have compared this drug with the standard antibiotics, but there are limited data which is published in the IDSA. So this is one model of a study, like catheter-associated UTI, gram-negative ESBL. Patients were randomized into Celoris or to meropenem, and they were treated for 14 days, and that the patients were compared with the end of treatment to around 3 weeks in the follow-up period. And the conclusion of the study is that it is found to be non-inferior to the use of meropenem. So these are the inclusion as well as exclusion criteria. This is a study which has been given to me by Cipla. So there is a non-inferiority of this combination to meropenem, and it is quite useful in treating MDR as well as XDR bacteria. What is the dosage that is to be used? It is about 1.5 gram to 3 gram every 24 hours or twice daily, and the maximum dose that is recommended is about 6 gram per day in 2 divided doses. These are the recommendations in children. And in with patients with impaired renal and hepatic clearance, you have to use the daily dose should be limited to less than 3 gram. And the antagonistic effects have been observed with the combination of chloramphenicol and ceftriaxone. And the caution should be exercised if concurrent administration of ceftriaxone with chloramphenicol is used. And it is ceftriaxone can be incompatible with vancomycin, fluconazole, and aminoglycosides. These are the drug insert data. And there are problems with the use of this combination, especially in preterm with hyperbilirubinemia. And there can be problems with interaction with calcium-containing products because EDTA is a chelator. And hypersensitivity as well as anaphylactic reactions are all described again with this molecule. So I'll just go through my renal transplant data. We usually do about 2 transplants per week. And this is a data which has been from October 1st to December 24th of this year. And the total number of transplant cases that were done were about 20. And we have got a slightly higher incidence of urinary tract infections. Around 11 patients out of 20 had urinary tract infection, and cultures were positive in about 9. So cultures were negative in about 2 patients, and cultures were positive in rest 9. And the gender distribution was about 4 patients were males and 7 patients were females. And the majority of the patients were asymptomatic, and we picked up when we evaluated these patients for a mild rise in creatinine or mild rise in C-reactive protein or a procalcitonin. And the rest of the patients were symptomatic. And the organisms which have been identified are E. coli in the vast majority of the patients, 6 patients, Klebsiella pneumoniae in about 2 patients, MDR E. coli in about 2, and XDR E. coli in 1 patient. This patient actually did very badly, and we had to initially we started him on meropenem, and subsequently we had to change over to Eloris because after some time we found out that the only thing that was the patient was sensitive was colistin. And colistin in a patient with a graft dysfunction and again associated with the problems. This point was actually highlighted in our interaction with Dr. Bensal. So we had a same meeting around 2 months back, about a couple of months back, and I think many of you have attended that meeting. And he suggested that this colistin, being nephrotoxic, they were more in favor of using a antibiotic resistance breaker like Eloris, because you can avoid the use of colistin, especially in a transplant setting with the creatinine going up. So this was I think is a valid point. So nowadays we use more of Eloris for our patients rather than use colistin and keeping our fingers crossed. So the key takeaway points is that charges double resistance mechanism, and EDTA is an antibiotic resistance breaker when added to ceftriaxone sulbactam, and it makes more susceptible against gram-negative pathogens by combating multiple resistance mechanisms. And ceftriaxone sulbactam EDTA is indicated in ventilator-associated pneumonia, bloodstream infections, and complicated UTI. And EDTA aids in better penetration of the drugs, increased periplasmic concentration, and hence enhanced activity. Degradation of the biofilm, inhibiting the transfer of plasmids, inhibiting the efflux forms, and increasing the periplasmic concentrations are the major mechanisms of action of this antibiotic resistance breaker. And to add, we have treated close to around 7 or 8 patients with Eloris, and I found out that I find that the results are quite satisfactory. Especially the major advantage is that we can avoid the use of nephrotoxic antibiotics like colistin in these patients. So this is a major advantage when compared to when it is analyzed from a renal point of view. So I'll just finish by my talk with a quiz. This is primarily targeted at the postgraduates who are attending this meeting. So how does an antibiotic resistance breaker work? So the choices are: it increases the membrane permeability of the drug, it prevents the transfer of plasmids by inhibiting the conjugation, blocks the efflux forms, prevents target modification of the drugs, and all of the above. So thank you. Thank you, sir.